Good morning. I know everyone's very excited after the last panel, but we really want to try to stay on schedule. So if folks who are going to stay could take a seat, that would be fantastic. Okay. You ready? You ready? Dr. Dube, you can hear me?
Yes. Good morning,
okay,
Brett.
Great. All right. Well, good morning, everybody, and welcome to this panel. It's called Rare Diseases. It's time to address this health equity crisis. My name is Dr. Britt Weinstock, and I'm the moderator of today's panel. Before I introduce the three very impressive panelists that we have, a gentleman who's virtual, which you can see there from California, and then the two on this side, I really want to thank Dr. Gary Puckrin, I saw him somewhere, and Mr. Brandon Garrett for inviting me to come back home to be here. And then I also wanted to thank Congressman Robin Kelly for putting this summit together again. So we only have 1 hour, unfortunately. So rather than rattle through everybody's bios, because everyone is so accomplished, and we would be here literally until tomorrow if I did that, I'm going to encourage folks to go to the bios that we have and just sort of launch into the panel. So on my left, I have Mr. Howard Mosby, the treasurer of the HEAL Collaborative. To my right, I have Ms. Molly Ryan, the Vice President of Government Affairs and Policy at Global Blood Therapeutics. And on the screen joining us from the West Coast is Dr. Eric Dube, the President and CEO of Travere Therapeutics. So in researching today in this panel on the topic, one thing that really struck me was that 30 million Americans in this country today are living or affected with a rare disease. And when you think about it in other terms, it's like 1 out of 10 people, 1 out of every 4 people on a bus. And so to me, in my mind, there's nothing rare about this. And so that's why I'm here. But I wanted to kick off this session and just ask the three panelists, what inspired you to come here? I'm gonna start with Dr. Dube.
Yes, good morning, and thank you for the invitation. I'm sorry I'm not there in person. What inspired me is really when we look at the statistics, it's very clear that there is work to be done. And, I think it's not just about statistics, it's about the stories that we hear every day. Britt, you point out that rare disease may sound rare just by the nature of the name, but they are not rare when you see how many individuals are affected. And when you see the statistics of outcomes that are affected worse in communities of color, it means that there's a lot more work to be done as we see this wave of innovation coming ahead of us. We've got to make sure that we're doing our part to ensure access to the proper diagnosis and the proper treatment.
Great. Thank you for that. I like the they're not rare. That was good. Ms. Molly?
Sure, thank you. And would like to just acknowledge the incredible leadership of Dr. Gary Puckrin and his team. Brandon Garrett, thank you so much for reaching out and inviting me to participate in this panel. I think what inspires me to be here is our community, right? Our community is suffering. Our community has been neglected. Our community needs attention. Rare diseases, especially for those that are suffering from sickle cell disease, have been neglected. And that is what inspires me to be here today, to be part of this incredible panel, to talk about some of the impacts that are happening within our community that have been left behind.
Thanks for that. Mr. Mosby?
Yes, and I'd like to also thank NMQF for putting this together. This is awesome, and having us come together to have these important conversations is indeed important. I want to also say that HEAL Collaborative, like Molly said, that we are in the community working with faith-based institutions to try to help them be better in this space. In many ways, they are first responders in dealing with issues related to health in our communities. We want to give them the ability to be able to have those conversations. And in the rare disease space, a lot of times the community really doesn't understand what rare versus non-rare is. And so we want to be able to have those conversations and help them come along.
Great, thanks. So everyone's touched upon sort of the health equity angle of this, and I'm just going to throw out to the panelists. How do rare diseases disproportionately affect racial and ethnic minorities? What effect does it have? I'm sure it cuts across all the social determinants of health, but if whoever wants to speak to that could speak to that, because that's really the umbrella under which we're having this conversation today.
I'm happy to jump in. Unless Howard, you.
No.
Rock, paper, scissors? Okay. I'm happy to jump in. Just to give everybody, I know you've seen it in your backgrounds, my organization, Global Blood Therapeutics, we're focused on one thing and one thing only. That is sickle cell disease. You don't have a lot of companies that are invested in just one specific area, especially in the biotech industry, but we are at GBT. Our job is to wake up thinking about what could we do differently in our communities of color, but more importantly, what can we do to bridge that gap between care that is actually not existent in some cases, especially in adult patient population for sickle cell disease. One of the things that we are thinking about every single day as well is 1 in 100,000 patients are living with sickle cell disease in the United States. What could we be doing in our position here at GBT, at Global Blood Therapeutics, to bridge that gap, to Britt, your point, bridge the gap in inequity? We know there's significant inequity that is happening within this patient population. Bridging that gap between pediatric and adult care, making sure individuals living with sickle cell disease have enough resources, have educated in terms of what to expect, and also raising awareness in our communities so that those that have sickle cell trait also know what challenges are there ahead of them. So at the end of the day, it's us at Global Blood Therapeutics really putting the patient in the middle of every single thing we're doing, and then thinking about what are the wraparounds that need to happen for that individual so that care, that transitioning care between pediatric and adult care is absolutely seamless. We have a long way to go, a long, long way to go. So thank you, I yield back.
Dr. Dube?
Yes. So we're part of Travere Therapeutics. We focus on rare disease exclusively. And one of the areas that we're focused on is rare kidney disease. And when we know that kidney disease disproportionately affects patients of African descent, Black community is disproportionately affected by kidney disease overall. That's no different when we look at rare disease. And when we look at some of the components of health equity, we see that diagnosis takes longer for patients who are of African descent, Asian descent, or Latinx. We know that access to genetic testing and newborn screening is an issue, and that diagnosis doesn't have to be determined by where you live. But I think perhaps even more powerfully than the statistics is a story. I want to tell you the story of Kevin, who is one of the patient advocates that we work with, who was affected by a rare kidney disorder. And it took him years to get a diagnosis. And it's not just the time it takes, but the toll that it took on Kevin when he was asked by his providers, well, are you eating unhealthy food? You need to stop eating fried food. You need to stop taking drugs. None of which was true. And it's an example of provider bias where just by listening to the patients and understanding what's going on may have allowed him to get an appropriate diagnosis sooner. So it's the journey to diagnosis that's an issue, but then it's also the access to care. We know that access to clinical trials, which is oftentimes the lifeline for rare disease patients, is even worse within rare disease. And that's part of the reason why we at Travere and many others have really formed the Rare Disease Diversity Coalition with the Black Women's Health Imperative to really address specifically health equity issues within rare disease that oftentimes are overlooked in the broader healthcare arena.
Thank you.
And I will just piggyback on what Dr. Dube said in terms of our work in this space around rare kidney disease, working with organizations like NMQF International and working with Travere. It's important to know that if you look at how rare diseases are classified and the issues that the rare disease community that they face, it's almost looking at the social determinants of health criteria, the same things that the rare disease community experiences in the healthcare delivery landscape is the same thing that minority communities experience. So from a minority, for underrepresented communities, when you say rare versus their normal disease state, it looks the same. And so they don't expect anything different from the healthcare system than they're getting if they have diabetes or have APOL1. So what we're trying to do is make them understand that the work that we're doing here is to try to help communities of color be healthy in this space and understand all the nuances around these diseases.
Thank you. I have a direct question. I'm punted to Dr. Dube and to Ms. Ryan. I'm thinking about getting screening, and people talk about getting screening, getting diagnosed. And Dr. Dube, you talked about how American diseases tend to be more aggressive. So it's almost, I know that if you get something diagnosed sooner, you can make lifestyle changes to stave off the progression until something comes to market, okay? Sickle cell, that's been around since forever. Here's my question. Given the number of screenings that newborns go through, they test them for everything, stick their feet, go up their nose, the whole nine. Why isn't screening for, is it for sickle cell? And why don't they screen for rare kidney disease in newborns?
Dr. Dube, you want to go first?
Sure. Well, we know that while newborn screening has been around for decades, the technology is not modernized. And we also know that the investment varies from state to state and zip code to zip code. And so there really needs to be a greater effort and investment to modernize newborn screening. About 70% of rare diseases are genetic in nature. And one example within kidney disease is APOL1 that Dr. Mosby mentioned. There is an opportunity for us to intervene and screen earlier, but not all of these diseases are presented at birth. And so there really is a need for a more comprehensive assessment, looking at risk factors, family history, et cetera. And we also know that a lot of the access to geneticists is determined by socioeconomic status and geography. And so there needs to be a focus not just on modernizing newborn screening, but also in creating greater access to geneticists that would hopefully be able to close some of these gaps. But in the prior panel, there was also a discussion of trust, and there needs to be, I think, a rebuilding of trust in genetic testing, in clinical trials, in access to quality healthcare. And I think that's a key aspect of all of this that we're going to need to address. As Ms. Ryan said, it takes a lot of work ahead of us.
Yeah, thank you. And let me just piggyback on what Dr. Dube mentioned. So 1 in 100,000 individuals, majority of them African Americans, are born each year with sickle cell disease. Each year, 1 in 100,000 in the United States. 1 in 100,000 children are born daily in the continent of Africa with sickle cell disease. Annually, daily. Those are the two different key variations. But when you look at, I think, Britt, coming back to your point, sickle cell disease has been here forever. It's been here for a very long time. It was the first genetic disease to be identified in the world over 100 years ago. And yet, we have 4 drugs in the marketplace for sickle cell disease. It's not sexy. Sickle cell disease is not sexy. It's not one of the diseases where you're having a lot of organizations, innovations jump in to try to produce the next generations of cures and treatments. It just isn't. It's a disease that's debilitating, that's very chronic. Patients who are, we've got pretty good care, pediatric care in the United States for those living with sickle cell disease. But once those individuals become adults, they're hitting a cliff. They hit a cliff because there are no adult sickle cell centers. There are some that are very few, like Johns Hopkins. They have a great program. But imagine if you live in Southern Maryland, to travel 3 hours away when you have a crisis to go to Johns Hopkins to get care and treatment. There's a huge disparity that is happening. 100 years ago, we have 4 drugs. 2 of them are disease modifiers. 2 of them are symptomatic treatments. And yet that's how we've come, how far we've come in the advancement, especially for treatments in sickle cell disease. As I mentioned, there's so much work to be done, but there's also, I think, coming back to Dr. Dube's mention about trust in the community, trusting in signing up for clinical trials. Because if we're underrepresented, the African-American community in these clinical trials, there's not a lot of innovation that's gonna happen because we don't understand the disease fully enough to make sure that we are represented across the entire board. I'm not talking about sickle cell disease because we know a lot about sickle cell disease. I'm talking about all the other rare diseases that impact our community significantly. Just we're underrepresented. And I think the urge here and the call to action is not only signing up for clinical trials, it's that's education and awareness, trust within our community that, you know what, there is good. that is happening, especially as it relates to innovation? And how do you become part of that ecosystem?
Thank you. That's sobering. Thank you. I'm going to sort of piggyback on what you said because the topic of innovation and investments has come up. And I'm just curious to see where things are in the therapy pipeline. And more importantly, not only get a sense of where they are, but I would love to see, get advice from you as a former elected official, what elected officials could do more to help facilitate that, either through accelerated approval or a lot of the other terms and topics we've been talking about, hearing about for the last few months. So, I don't know if you, Dr. Dube, you want to go first?
I think Dr. Mosby was, or Mr. Mosby was going to add.
Well, there was a lot to unpack there.
Sorry.
So when we look at investment in this space, what's happening with advocacy organizations, specifically in the rare disease space, I'm trying to pick a politically correct term here. It's poor. There's poor investment in this space, and we really need to see more investment in this space. We talked about the issue of trust. In order to build trust, you really trust is about consistency. I was having this conversation last night. I can't determine exactly when I fell in love with my wife, but it happened over time. And the community who's experienced this trust piece has to see this investment improve over time, and that it's meaningful investment and not just a box checkoff. As a former elected official, I know for a fact that many of my colleagues are former colleagues now. I'm a reformed. I got my senses and got out of that mess. But anyway, many of my colleagues are unaware, and they're unaware for a lot of different reasons. There are some, thank God, that really take into the space, but many of them really don't know, and it's that education piece. As we're educating the community, educating policymakers to be more impactful in this space, and we are woefully inadequate in the amount of information that's coming forward in order to address some of the issues that are affecting our communities. And so forums like this are extremely important for us to keep the ball rolling.
Yeah, and if I can add, I think it takes everyone working on these issues to be able to address the gaps that we see within rare disease. And I think, with that, I want to really offer a strong message of hope because, things can improve. If we look at what the Ryan White Act did in the early days of the AIDS epidemic, that was Congress really acting with community. When we looked at the Orphan Drug Act decades ago, that spurred an investment in innovation within rare disease where there really was none. And I think today there needs to be a rallying cry as we recover as a nation after COVID to really address the issues of health equity. One of the aspects that I'm excited about is a new bill, HR 7506, that really is the era of preventing end-stage kidney disease. And part of this is to address health equity within rare kidney disease. And I applaud Congressional Black Caucus member Mr. Butterfield, along with Congressman Bilirakis, in introducing HR 7506, because this really calls for an investment in NIH to better understand kidney health, to invest in communities of color service program to better incentivize nephrology fellows who are disproportionately affected, as well as to support provider education. And there's also a request in this bill to invest in research in the social determinants of health and treatment patterns amongst people of color who are disproportionately affected by kidney disease, including rare kidney diseases. So I think, Britt, to your point, there is a need and a role that Congress can play, but it's not alone. It's going to require industry, community, it's going to require providers as well as government to be able to work together to address some of these challenges. But again, I offer that as a message of hope that there is a way, and there is, I think, a greater awareness around the need to do things differently.
Yeah, let me just piggyback, I think, on the 2 points that have been raised in terms of Congress and the incredible efforts that have happened in order to fuel the next generations of innovations. I think Dr. Dube just mentioned the orphan drug tax credit. That incentivized a lot of companies to jump into that space. 21st Century Cures, an effort that emerged out of the House with Congresswoman Diana DeGette and Congressman Fred Upton. That incentivized a lot of companies to think back and say, what else could we be doing? What manufacturers especially, what could we be doing to innovate the next generations of medicines? I also want to add that it does all these things, I think, as mentioned, don't happen in a silo. They happen because not only is Congress taking an active role in pushing forward policies to improve greater innovation, it also happens because the voices of the community are rising up to say, why don't we have X? Why don't we have Y? Why don't we have Z in the community? It also has to happen because in the provider community, you have individuals, right, that are jumping into taking care of individuals living with rare diseases because there are incentives in the system. And I hope you don't take this lightly, because when you see a sale, buy one, get one half off, right? Don't you jump on it like, oh, I definitely want to sign up for that. When you go into a store, buy one, get one half off. You get excited about that incentive. The system needs to be incentivized so that the next generations of innovations are coming out of it. And it has to happen across the board, not only just in the manufacturer setting. Loan forgiveness for those that are interested, especially in underserved communities, getting into rare diseases. Loan forgiveness is a pretty big deal. You're not only going to have physicians going into a plastic surgeon, which is high return on the investment in the provider community. They're going to jump into taking care of individuals living with rare conditions because there are incentives that have been placed in the system to make that happen.
Okay, thank you. Ooh, that's a lot. So I'm just looking at this room, and I just have a question, because I see there's tons of doctors, nurses, PAs, folks in programs, folks who educate folks in programs. What would we recommend to the provider community overall to do more to educate their patients? Not that you're not busy enough, not that you already don't try to do that, but what steps can be taken to raise greater awareness? Because from everything that I hear from people, they don't bring up kidney health until you have symptoms, And there was a very famous basketball player, and he received a kidney transplant. He had a rare kidney disease, had no idea, and I had the chance to meet him, and he was in tip-top shape. He was the size of a giraffe, as tall as a giraffe. I think he was like 3% body fat, had access to the best doctors, the best healthcare in the country. And he found out that he had a problem when he went to the bathroom, and he said it looked like Coca-Cola came out of him. Not to get graphic, but that's how he found out. And so what can we do as a community? And to Dr. Dube's point, it has to be everybody, but what can we do to more engage the providers who are more likely to serve and have the trust of the very communities that we're talking about that are disproportionately affected by these conditions?
So I actually want to piggyback on something that Molly said as well. The provider pipeline is extremely important. When you start looking at it, specifically in the rare disease space, rheumatologists, endocrinologists, even nephrologists, it's not as sexy, to use that word. It's not as sexy as a place to go. The salaries are not the same. So if you're going to spend $500,000 on medical school, you're going to try to pick a specialty or a subspecialty that will actually get you the kind of return on your investment that you're looking for. The highest need in the community centers around how primary care physicians refer to specialists. And we need to really look at that pipeline as a public health crisis, to me. And I think that we need to do more in that space.
I think in addition to that as well, and I think that's a great point, Howard, is our community aware of the opportunities that are outside of You go the traditional route of becoming a physician. You go the traditional route of becoming a healthcare provider. There are opportunities that go and extend beyond that in the biotech industry, in other industries that are touching the healthcare ecosystem. There are opportunities across that entire spectrum for our community to jump in to say, that's an interesting career choice, but you actually wouldn't jump in there if you necessarily don't know it exists.
Right.
These conversations here that we are having, the conversations that are convened by the National Minority Quality Forum every year. I've been coming to this conference, I don't want to date myself here, for a good bit of time, right? A little over 2 decades. It's these conversations, it's making sure these conversations are translating to our communities, to reach individuals to think, in not even that, it's not that early when you go to elementary school. I have a public educator as a husband. It's not that early to have our community go into the public school setting, elementary, middle school, high school, all the way to help individuals start to cultivate those seeds to think, oh, wow, that could be an interesting career for me, and that could be a career choice. So that we're not only growing a small segment of the next generations of physicians and healthcare providers, we're creating a broader community of those that are invested, that look like me and look like a lot of us in this room, right? The next generation of scientists, the next generation of individuals that are interested in the healthcare ecosystem.
Thank you. Thank you.
Molly, I couldn't agree more. And I think that's an absolutely critical place for every one of us to start in investing early in STEM education, for example. And I'm proud that we support in the Southern California area an organization that really matches our scientists, particularly scientists that are often underrepresented in medicine and in STEM, in the STEM field, to partner with school-age children, to have them the ability to see that science can be for them and that they can see themselves in the medical field, in the biotechnology field, et cetera. But I think we also need to make sure that we're doing what we can do now to impact the delivery of quality care. And this is where, for example, I mentioned the Rare Disease Diversity Coalition, the RDDC. One of the main priorities for this work is cultural sensitivity training for providers, so that when they are engaging with a patient with that potential rare disease, that they're asking the right questions and they're not making assumptions. One of the things we like to talk about in rare disease is to really overcome one of the key tenets of education in medical school, which is looking for horses versus zebras. Now, bear with me on this analogy, because I think you'll see in rare disease that oftentimes the zebra and zebra stripes are sort of the logo for rare disease. And it's because oftentimes physicians are taught, when you hear hooves, think horses, meaning when you see a symptom, think of a common disease like diabetes, like hypertension. And they're trained not to look for rare diseases or ask the questions. And I think it's an opportunity for us to really have not just cultural sensitivity training, but also to raise better awareness and asking the right questions, so that you're not having those sort of biases come to the forefront when you're engaging with patients. So I think that, we need to start early, but we also need to start now with where care is being delivered for communities who are affected by rare disease.
Yeah. That's a great point.
Can I add something to that? And it was stated in the last panel, you really can't get away from the health plans in this space, how reimbursement happens. And we really need to bring them to be a part of this conversation, because if we're not talking about how things are getting paid for, then we're really just having a philosophical conversation. That's right. So I think we need to really bring those health plans to be a part of this.
Yeah, I was just going to add one thing, Dr. Dube, because you brought up sort of bias in healthcare. People have been talking about trust in healthcare. And I just wanted to mention there's a bill that's dropping out tomorrow, in addition to the bill that you mentioned, Dr. Dube. It's called the Health Equity and Accountability Act. I'm sure people have heard about it. Congressman Kelly is introducing it as the Tri-Caucus Health Disparity Elimination effort, but there's an entire new title around implicit bias. And the role of implicit bias is just as important as explicit bias, because that cuts across everybody, and even the most well-intentioned doctors and nurses and dentists of color have these implicit biases that they bring into their healthcare settings. And so that's a really important piece of it as well, because the story you told about the young man, Kevin, that's horrifying. But I have seen that, that happen time and time, and I've stories you hear time and time and time again. And sometimes it's a white provider who's doing it, but sometimes it's a Latino or it's an African American. So you just never know the role the implicit bias plays. So I think that's a really important element to keep at the table or on the table. So. All right, so I'm just looking at the time, and I want to make sure that we stick to time, not just because we were given an hour, because I know lunch follows this, so I'm not trying to get jumped, but I also want to have enough time for Q&A. So if folks have any questions, please feel free. I think there's mics around the room, or you can probably just shout, because the room isn't that big.
Good morning. I'm from Coppin State University. I appreciate the comment about giving cultural education to nurses, nurse practitioners, and the doctors. I think we need to take it back to the basics on education and culture, because it goes a lot further to understand minorities. A lot of times we do not go to the doctors until it's really severe. Spiritually, we believe that God is going to heal us. So we need to look at the bigger picture a lot of times, and we don't want to be stuck with a bill. So if that's, versus surviving, thinking I need to pay my rent or something like that, versus healthcare, we're trying to survive a lot of times in underserved, underrepresented communities. So I say that piece. And then the other thing is you spoke about recruiting doctors and possibly nurses and nurse practitioners. What are we doing after we recruit them and get them into school? Or what are we doing to retain them in these fields? Because a lot of times they get in school and then we talk about diversity and getting that increase in the numbers, but what are we doing to maintain them continuing and finishing school?
That's a great question.
I'm happy to answer the second part of your question. And I'll also address just a little bit of your first, I think, point in terms of going beyond, when folks are talking about healthcare professionals across the board, nurses, doctors, et cetera, we at GBT are thinking about how do we actually partner with churches? How do we actually go even more localized to really continue to raise that education and awareness? At GBT, one of the things that we're focused on is, I think to your point, is once somebody gets into medical school, how do you keep them interested in that specific career, not only through potentially scholarships, but how do you ensure that they're coming back into our organization at GBT through fellowships so they can become part of the fabric of the organization, and they can become part of the fabric of the healthcare ecosystem. So because we're not only in a silo in biotech, we're working with those health plans that Howard mentioned. We're working with PBMs, we're working within the community, is that then those individuals become part of the fragment of our organization and the community at large. So it's taking that a step further in, you're not only getting funding to attend school, but we're incorporating you into our own culture at GBT, so that you're seeing it from all the lenses.
And I'll jump in here. It's almost a setup question for me, because we we work with churches right now as ground zero for the activity that we do. Just about everyone who's a member of a fraternity or sorority or any kind of group invariably goes to somebody's church, or their mother goes to church, what have you. And we feel that we can get that church, who still in our estimation is still the most trusted voice in communities of color, working down that particular avenue. I would agree wholeheartedly with you that we need to show up that piece of the engagement. It's hard to see. We have to show up that piece of the engagement so that that the church is better equipped to be able to handle it and handle issues in that environment, and not just say, we're going to pray for you. But actually we have resources that we can point you to say, this is where you go to get this kind of information. But But let's be real in this room here. Healthcare is not easy to navigate. When you step into a hospital, I don't care what kind of degree you got, when you step into a hospital, generally is at the worst possible case of something that's going on with you. And at that particular point in time, you don't hear anything except for, I got X, whatever that X thing is. And this education piece has to happen on the front side. You can't be paralyzed in your approach to healthcare. You can't let it sneak up on you. It is going to happen. Being more proactive in this space is the way that we save and make our communities healthy.
Mm-hmm. If I can maybe add, I think, Mr. Mosby, what I hear very often in the stories that I hear from patients with rare kidney disease is just that. They're diagnosed late. They eat, despite having been shared by a physician earlier that, oh, you've got, protein in your urine, et cetera. They're diagnosed too late. And what they hear from their clinicians is, you're just going to need to wait until renal failure and dialysis. That is unacceptable. And it's going to take working with places of worship, working with local providers, and empowering communities to make sure that they are asking the right questions and demanding the right information from providers. I know that that's easy to say and very challenging. We hear the same thing. One of the members of the RDDC is Dr. Rios from the National Hispanic Medical Association. And she outlines very clearly within the Latinx community the challenges of uninsured rates, working essential jobs more often than not, where being able to even travel to a specialist can be a challenge. And we know that across the board nationally, that rare diseases cost over $1 trillion. That's not just to health plans, that's to families as well. And we need to make sure that we're addressing this holistically in order for us to say we're going to empower communities to seek better care, et cetera. It takes a lot of effort. And I'm hopeful, Britt, that the bill you mentioned that's coming tomorrow will be able to tackle a number of these issues that we see when you start to pick apart the barriers to health equity.
Yeah, that feels like 1,000 pages long. It's like this thick. I wanted to touch on one thing that you brought up, which I also think is very important, and I wanted to also get to the young lady. There you guys see, okay. But I'm going to get to her first. And as it pertains to looking at schools and HBCUs like Coppin, I went to Howard, and I'm very proud, Mecca, all the way. But I also saw how under-resourced that university was compared to, I did my bachelor's at Bucknell and my master's at Georgetown, okay? So I go to this flagship HBCU to get the highest of my degrees, and just the lack of just investment from the people who are writing the checks in a lot of these institutions is impossible to not see. And it's not that there's no want or will, but it's very difficult to ask a professor, and I'm sure you know because you're at Coppin, that's already doing so much. They're not just professors and best friends, they're counselors, they're the shoulder that people lean on. A lot of times they write checks when you can't afford your books. And then to ask them to take on even more responsibility without resourcing them well is, that's a huge problem. And I think I don't have an answer to how that could change, but I do know it needs to, because these universities are the ones that are graduating the largest numbers of people who, some look like us, some don't, but they're disproportionately more likely to serve in an underserved community because that social justice element is just integral to the curriculum. So I think you raised a really great question. I don't have an answer, but I just wanted to say to you, thank you for raising that, because that's something that often gets lost in the shuffle. I see.
Awesome. One, thank you so much for this. This has been a really awesome and robust conversation. So there's a lot of research that points to greater health literacy really improves health outcomes. And when you look at the intersection of diverse populations, low health literacy, and then you compound that with really complex and challenging conditions like rare diseases, how do each of you see changing that landscape to improve health literacy, either through programs and or policies, particularly for the rare disease community? Thank you.
I'm happy to jump in. I think it's a fantastic question. Health literacy, right? top of the agenda. 50, I want to say a little over 50 years ago, there used to be PSAs on sickle cell disease, right? To increase that awareness, increase that education. And then for some reason, that information just kind of died on the vine. And we at GBT are trying to think about how do we resuscitate that health literacy, those programs that made such an impact 50, 60 years ago when we used to hear PSAs about sickle cell disease. And we're partnering, coming back to my earlier point, with the faith-based community. We have a pilot in Georgia with 100 Black churches to educate on sickle cell disease. We want to take a temperature check of that pilot and take that pilot to other states so that it's not operating in a silo in just one state. It's across the entire country. And that health literacy is absolutely key because now we're taking it down to the grassroots level. It's not only just on the national level where we're talking about sickle cell diseases. How are we going back into our community to really talk about a disease that significantly impacts us? So that's one area that I think health literacy, absolutely critically important, but I think it has to be on the grassroots level.
Yeah, and can I just dovetail on that really quickly? I would also say, just for folks to remember, I'm a huge proponent of community health centers. I think the work that community health centers do across the country and just the mainland and in the U.S. territories is unbelievable. And I think engaging the community health center world is also vitally important because everyone in this room knows back in March of 2010, when the Affordable Care Act was passed and signed into law, one of the big pushes was for the underserved to look at community health centers as their medical home. And a lot of people did that. And the providers in these centers gained the trust of people who otherwise did not trust the healthcare system. So I would just say that they have to be a big part of this health literacy kind of campaign that we're talking about.
And I would add that the key thing to both of these was the word trust. And even though you might be bringing information, the information has to be trusted. It has to be written in a way that the community can digest it. And in a lot of ways, a lot of times that information is not set up that way. And the community then rejects that information just outright, and you find yourself trying to rebuild that. And rebuilding trust is so much harder than just coming with the right plan the first time, so.
I would agree, and maybe I can add just an example of what Mr. Mosby mentioned. I think we've got to make sure that we are looking at all aspects of where people engage in the healthcare system. And when we think about that within rare disease, of course, a lot of that has to be early on and grassroots and making sure that there's greater awareness of rare diseases like sickle cell, like certain kidney diseases. But for many patients, once they are diagnosed, the only offer is either an off-label treatment or a clinical trial. Now, oftentimes, this is where there's the greatest source of mistrust in clinical trials, and for good reason. But what we've got to do, and I think one of the areas that the Rare Disease Diversity Coalition is focused on, is demystifying what a clinical trial is. And when you're enrolled in a clinical trial, you go through a battery of tests, but you also are given a very, dense document, informed consent. Now, I don't know about you, but when I read a document like that, and there's a lot of legalese, it's not going to help in building trust necessarily. And so how do we apply health literacy and just engaging in a better way to talk about aspects of healthcare, clinical trials, et cetera. And I think that those are some of the things that we're working to demystify and helping to really ultimately get better awareness and empowerment within communities so that they can take advantage of clinical trials or access to care once it's there. But it's going to take, again, a multifactorial approach to addressing these.
Can I just say one thing for what you just said, Dr. Dube? Because just came across a bunch of studies from, I think it was last month in JAM, and they had a study. 2 months ago, and it looked at referral into clinical trials and how seldom an African American or a Latino is even referred, because there are these value judgments that you're not going to stick with the trial. It's going to be too cumbersome. You're not going to adhere. You're not going to do any sorts of things that people give a non-minority person the credit with doing. So I think it's important to recognize that. The other thing I think is equally important is that we talk about clinical trial diversity all the time. We always talk about it as we are the participants, as the patient, either with a placebo or with the experimental drug. We also could be clinicians. We could be the principal investigators. We could play stronger roles as the recruitment individuals, and equally important as the analyst that analyzes data and then spit it out. So we're not marginalizing anything that looks at a particular racial ethnic minority group or a subpopulation group. So I think that the diversity piece has to be completely expanded, and the conversation has to be expanded, so that we remember that we need to be represented at all levels of clinical trial from the beginning to the very end.
Right, and Britt, let me just add that most CROs, right, these are the organizations really that partner with manufacturers like us to administer these clinical trials. Most of the CROs don't look like the majority of this room. And that's another area that we need to diversify, is the makeup of the CROs and who's representing us as individuals of being asked to participate in clinical trials. If you don't see somebody that looks like you or that has your same background, you're naturally gonna go, what are you trying to sell me? So that's another part of the healthcare ecosystem that really needs diversity.
Yeah, definitely.
Thank you. Willarda Edwards, physician in Baltimore in internal medicine. Dr. Weinstock, it's good to see you again.
You too.
And I've also had the privilege of being the president of the Sickle Cell Disease Association of America until I became president then of the National Medical Association and stepped down from my role at SCDAA. And also had sickle cell, a little sister who died at age 15 months because she had sickle cell disease. And of course, that was before I became a doctor, and my family was more aware of the need for doing sickle cell testing and finding out whether we had trait. But my point that I wanted to bring up is that, yes, it was like 2010 when I left SCDAA, which is a community organization that's focused on trying to support families with sickle cell and raise awareness. One of the things that we had issues with, and it's obviously still a problem today, even with the orphan drug tax credit, funding, is the funding for both research and then the support of folks getting into clinical trials or being involved in clinical trials. That whole issue that was brought up, I think Molly brought up the fact that there's a gap between when they're born and they get diagnosed, and then once they get to be adults, they can't find internists like myself to be able to provide the care that they need as an adult. Funding is still an issue, and yet when I was the president of SCDAA, we would look at getting some funding through pharmaceutical companies. And when we compared ourselves to other rare diseases like cystic fibrosis, who they seem to have money coming out of but I didn't say that. So the question I have then is, and can you comment on, what can we do better now? And does that tax credit really help in terms of incentivizing more companies to get involved in it and then provide more funding for communities?
Thank you. Thank you for that question, and amazing work that the SCDAA does on behalf of the community, and so many other organizations like Sickle that are really partnering with the community to educate, provide resources. Someone's not able to, pay for their electricity bill. They're stepping up because sickle cell disease impacts not only just minorities, but it's a hard hit on our Medicaid system. Let me come back to your point about funding. I am just excited because we are at the cusp of a new initiative that really pushes the federal government to fund a comprehensive care for sickle cell disease. What does that actually mean? It means that for those individuals that are in pediatric care, there's an opportunity for the federal government to step up and increase that level of funding to the tune of $500 million that will go towards centers of excellence, very similar to what you just described. It's available in cystic fibrosis, available in hemophilia. Why not in sickle cell disease? It is time. We have not seen any comprehensive measure in sickle cell disease since former President Nixon 50 years ago urged Congress to do something. We're at the cusp today. We're excited to partner with Congresswoman Barbara Lee from California. We're excited to partner with Senator Van Hollen from Maryland to introduce this legacy initiative. We're asking for the federal government to fund it at $500 million. $425 million would go towards the creation of the centers of excellence. It's not unusual to get that kind of funding for other diseases. And $100 million would go towards community-based organizations like SCDA and Sickle and others that are really connecting patients to care, that connecting family members to care and resources. And then at the end of the day, we have to be accountable for all those federal dollars that will be going towards the system. And we are asking for a national coordinator to help us better understand where the gaps are in the system, bridge those gaps. And even maybe that $500 million might not be enough. Maybe we might need a little bit more, but we're starting there. And we're excited to partner with these key legislators in the House and the Senate to introduce this initiative. Stay tuned, everybody, because this is coming, and I'm excited, so excited for the sickle cell community that this is gonna happen 50 years later.
Excuse me. I don't know if you. Hi.
Hello, is this mic working? Can you hear me okay?
Absolutely.
Hello, my name is Stephen Thomas. I'm a professor of health policy and management at the University of Maryland, College Park. And thanks to the National Minority Equality Forum, we're bringing COVID education and vaccines to Black barbershops and beauty salons. And you know what? I got a message from the barbershops. Nobody wants to go back to normal, because going back to normal means Black folk living sicker and dying younger. Here's what they asked me. Hey, Dr. T, you're going to that big meeting? Ask them this. If they can give us a life-saving vaccine in a barbershop or beauty salon, well, why can't they bring the diabetes test here? Why can't they bring the sickle cell education here? Why can't they bring recruitment to clinical trials here? How might we transform the sacred spaces of our barbershops and beauty salons into a place where people already have trust and bring these ideas and conversations there? Is that possible? Give me something I can take back to the shops.
You want me to address that? Okay. You're absolutely right. Barbershops and churches are kind of, they're nuanced. And so there are some barbershops that are very progressive. And then there are others that you walk in the door and they look at you like, why are you in here? You're not part of the normal group. So building the trust there also, it is exactly the same message that we have to be consistent in what we do here. The thing that happened with COVID was that it affected everybody. And so nobody could really hide from that. Sickle cell, let's use that as an example, is a Black person's disease. Now we know it doesn't just affect Black people, but that's the way it comes across. Funding comes across the exact same way. When you start looking at diabetes and you look at lupus, a lot of these organizations out here who are getting dollars are only approaching those communities when they want to raise money. They're not there to try to see those communities be healthy. I'm sorry, I'm trying to editorialize this, but it burns me. But a lot of times our community is at the end of the tail, and we have some crumbs left over. Let's throw some money over here and see what happens. We do need to be more intentional in that space. And I think it's barbershops, beauty salons, churches, wherever we gather, we should be providing health information so that we are, in fact, literate across all these different areas.
And I urge the gentleman that just spoke, we are about that intentionality at Global Blood Therapeutics. So if we hear a good idea, like the church, the pilot that we did in Atlanta, Georgia, that was an idea that was floated to our leadership team, that why don't we do something in a state that has a significant prevalence in sickle cell disease? Why don't we partner with churches? That was an idea that was floated. I love your idea of partnering with barbershops and hair shops to continue to educate and raise awareness for a disease that impacts our community disproportionately. We're happy to partner. See me after the break.
That's right.
And I can share that this is also something that can be done within kidney disease. And we're talking today about rare diseases, but we also know that kidney disease disproportionately affects the Black community. And we've seen early success in partnering with churches where we can provide that awareness and do protein testing there on site, because we do know, exactly as this gentleman said, there's greater trust in those settings than in saying, go see your doctor and ask them about the protein in your urine. I think there's an opportunity for us to do that, but it is going to require all of us in operating. And I think, as an industry within biotech, we all need to make sure that we are not just, I wouldn't even call it investing, it's giving to the communities that need this most. There's a real excitement around the innovation that's coming from this industry, but if it's only addressing people of higher socioeconomic status or white communities, that is not innovation. It's not enough. And I think we do need to find those great ideas to be able to reach it early, not, as Howard said, just when someone needs to raise money.
Right. We'll make sure the gentleman who asked the question, I know you have the hat on. We'll figure out a way to connect you with Dr. Dube and the folks here, because he seemed interested in that idea. So, we can probably share lessons learned. So we have time for one more question before we wrap this up and get fed.
Well, but I also want to respond back to we got someone over here. No, so we're working with NEFCURE and Travere in Atlanta, Georgia, at a specific church that's actually carrying this program out. It's a year-long pilot that we've been working on, and we established work groups, focus groups, where individuals are talking about FSGS. We're finding out that people who had the genetic mutation were afraid to tell their congregational members that I have this disease, feeling that they were going to be chastised about it, and being able to bring this information forward through working with companies like Travere, we were able to kind of break through on that. So I just wanted to give you kudos for that.
Thank you, and that dovetails into my question. And so you have the prop here. I see all the wonderful guest speakers and the panelists and the moderator, and I do see the empty chairs. I talk about it a lot when I travel. I see the empty chairs, and the empty chairs about the people who are not there or don't have a voice. And so you all are helping to advocate for those people who are not present, who have suffered these consequences. How do we make it resuscitated? How do we bring more advocacy? How do we bring more attention to those absent people, so that there's excitement about we need to invest that $500 million, so that the congressional members from the top down and the folks on the grassroots are talking up to make sure that that's the first and present proper mind.
Well, Mr. Clyburn, I fully concur, because I was just looking around and I'm like, we've got a good group here too. I mean, NMQF has done a pretty good job. But I always tell people, if you're not at the table, you will be served on it. And we know that throughout history. I repeat that ad nauseum. And then what I try to do as much as I can is show up and just keep talking and just keep banging on the door. If I can bring a friend, I'll bring a friend with me. But I mean, to your point, I do think that people who are most affected, sure, it'd be great to have them in the room, but we're also talking about people who are most affected. So some people can't get to the Watergate. They can't take time off of work. They physically or don't feel well enough to come to an event like this. So I think it's incumbent upon all of us to then provide a voice to the voiceless and provide their stories at these tables, so that everybody else can sort of apply the Trippy effect and just spread it out as much as possible, much like Dr. Dube did with Kevin. I had never heard that story before. The story was horrifying to me, or the story that you told, or Dr. Edwards, about her sister who passed away. So I think that just being cognizant that not everyone can be at the table, but also aware that when you're not at it, you're going to be served on it.
And I would also, and Absolutely, Britt. I completely agree with what you said. I think it's also important to take the conversation out of our nation's capital. In partnering with our legislators across the country. At Global Blood Therapeutics, we have a program that we're putting together in about 2 weeks with the National Black Caucus of State Legislators to talk about sickle cell disease and to showcase examples of which states are doing a great job, right? Is to make sure that those that want to model legislation, they have good examples to go from, that they're not recreating the wheel. They're saying, okay, California did it. How do we do what California did? Michigan did it. How do we recreate what Michigan did? Continuing to create the conversation out of our nation's capital and back into the states. That grassroots, I think, conversation that I talked about, partnering with community-based organizations like SCDAA and going and working with their local chapters to continue spreading that information and making sure that they have resources to continue to do that good work.
That's a great point.
And I would, and time's running out, but I would agree wholeheartedly with everything you said, Molly. This is huge.
Dr. Dave, you want to last?
Well, I am standing in the way between you and lunch. I would say the stories matter, but I came into this industry because I came out at the worst year of death in the AIDS epidemic. And I knew that you were only going to be seen if you advocate for yourself and you demand what is deserved. And I think that every community deserves hope. Every community deserves quality healthcare. And everyone deserves a treatment if it is available. And I think we need to demand that of one another. And I think that that's the other aspect of sharing our stories, but being an advocate every step of the way.
Yeah, great. That's a great final point, I think, to close us off on. Well, thank you to all the panelists. And thank you for all of you who sat in here and asked really good questions and gave us lots to think about. And I hope this was worthwhile. I'm wrapping it up.
All right.
Am I okay, Brandon? You good on time? Okay.